Hello, everyone, and thank you for joining me for the Speech Therapy and PDPM Zoom meeting and what it means for you. My name is Annalisa Torres-Aquino. I am the clinical specialist for Aspen Therapy, and I will be guiding you through today's presentation. Our agenda for today: we are going to review PDPM as it relates to speech therapy. We're going to focus on increasing understanding of and reviewing the importance of sections C and K. We're going to become more familiar with the sections C and K communication tools. We are going to look at the dysphagia medical workup form, and we'll review some operational updates. Hopefully all of my viewers have had the opportunity to go onto the Aspen Therapy website and view the sections C and K webinars that were recommended for viewing before we launched this webinar series. So what you're looking at right here is the PDPM speech therapy component payment group, okay? This slide shows the case mix, how the case mix group is configured by taking several things into consideration: the presence of acute neurologic conditions, speech-related comorbidities, or cognitive impairments seen in column 1, and the presence of a mechanically altered diet or a swallowing disorder seen in column 2. A sample configuration of a speech payment group. If you have a client with a cognitive impairment, dysphagia, and a swallowing disorder, for column 1, the cognitive impairment would classify as any one. For column 2, the dysphagia and the swallowing disorder would classify as both. The case mix group would be SF, and the case mix index would be 2.97. So in general, the more components that you have, the higher the case mix index, which impacts reimbursement. If you look at the last column, there's a range between 0.68 for none and neither versus all three and both at 4.19. The takeaway from this slide: it's important that our clinicians scour the chart and look at hospital records for diet alterations and swallowing issues, including those that are post-op. Moving on to speech therapy comorbidities, there are 12 conditions that are combined into one single speech therapy flag. Your client will flag if any of these conditions or services are present, okay? So these include aphasia, CVA, TIA, or stroke, hemiplegia or hemiparesis, traumatic brain injury, a tracheostomy while a resident, ventilator use while a resident, laryngeal cancer, apraxia, dysphagia, ALS, oral cancers, and speech and language deficits. Something to consider here: a facility may be incentivized to admit a more complex client, including those with vents or trachs, due to the financial bump for these patients. Moving on to MDS Section C. Everyone, again, should have watched the Section C video posted on the Aspen Therapy website. Our clinicians must remember that the BIMS is a screening tool, not a billable part of your session. It should take approximately 5 minutes to administer and 3 minutes to score, so ideally under 10 total minutes to complete. Detailed information was provided to our FRCs during their last training session and again can be found in the webinar. This includes how to properly administer and score the BIMS. On the BIMS, there is no scoring for severely impaired clients. For these clients, they are measured by the CPS, which is crosswalked in the table that you see here. MDS Nursing owns the completion of the CPS. In general, Aspen is not recommending that the BIMS becomes a part of our routine speech therapy screening, meaning we don't expect that the BIMS is done for every client in the facility. During screens, our speech therapists will also need time to take a look at swallowing and other speech-related issues. Our speech therapists are well-versed in completing the BIMS, and this is a value-added service that we can provide to our customers. So it is okay to perform on newly skilled admits and readmits and at the facility's request. We do ask that if your facility is requesting a BIMS on every client in the building, that you please discuss this with your operations team leader. This here is a snapshot of the Section C communication tool, okay? Be aware that there are other portions of Section C that we are not going to be contributing towards. Recommendations are to follow the cues that were provided in the training video to accurately administer the BIMS. In regards to the Section C training video, I do want to point out that there was an error in which the presenter used the word shoe instead of sock. For the first question that you see here, the series of words are sock, blue, and bed. This here is a screenshot of the BIMs and the Optima reporting. I do want to point out that at this time, our FRCs will need to record the BIMs data in Optima to generate the report for MDS, very similar to how they're entering in the information for Section O right now, but only for PDPM. This form here will include input from Section C for cognition, Section K, including swallowing and nutrition, Sections I, which includes active diagnoses in the last 7 days, and Sections J, which includes health-related conditions such as pain, dyspnea, tobacco use, and falls. This here is a screenshot of the scoring tip sheet that was provided to FRCs during their last training session. I would recommend that you either post this somewhere for viewing, or that you consider making a copy of it and keeping it with you so that you have it readily available when scoring BIMs. Moving on to Section K, communication tool. As you know from the webinar, it is essential to capture any swallowing issues or dietary changes and alert MDS. This tool is to be given to your FRC after you've reviewed the chart to provide thorough communication, and in turn then your FRC will provide it to their administrative team. Let's move on to the operational impact of PDPM, okay? We are asking that all disciplines will need to assess their client by day 3. This is Aspen Therapy's corporate standard going forward. If MDS is trying to capture something in a look back and using an early ARD date to capture, so for example, day 3 or 4, we will need all of the necessary therapy services in place and our findings thoroughly communicated. We'll need to make sure that our chart reviews are complete, that evals are in place for cognition and/or swallowing, that the dysphagia medical workup is completed and sent for signature along with the evaluation, and that any discrepancies found in data are resolved, okay? I do want to point out that the R13 series of ICD-10 codes are returned to provider codes, and they cannot be your primary medical diagnosis. You can, however, add them as a secondary medical diagnosis or use them in your treatment diagnosis areas. For speech therapy, there is no variable per diem adjustment like there is for PT and OT. Groups are now 2 to 6 participants working on same or similar tasks. We did complete a group therapy binder that was provided to all FRCs during the last training session. That should be located in your department now. The binder has several sections in it, including for PT, OT, and speech. I do want to make mention of the fact that even if something is not under the speech therapy tab in this group therapy binder, you can still use it. The idea behind these groups is just for general guidance towards a specific task. And if you have something that you found in the PT section or the OT section that pertains to what you're working on a group, you are more than welcome to use it, okay? And then a final reminder that diet orders, we should be noting texture modifications and making sure that we're continuing all other diet orders. We want to make sure that we are not discharging a special instruction like no sodium added or the request for a diabetic diet. I think that we can all see that this is going to be a very new era for speech therapists, okay? ASHA says we need our speech therapists to quickly identify patient-related needs. We need our speech therapists to play a critical role in determining clinical complexity of our clients, and it is essential that our speech therapists are contributing to the information that is being inputted on the MDS. So what now? I would recommend that if you have not, that you review the sections C and K webinars on the Aspen Therapy website under the employee portal. Is specifically located under the tab that says News Bites. Complete your communication forms and make sure that you're sharing them with the FRC so that they can in turn share them with the administrative team. And make sure that you're addressing any operational questions or concerns that you have with your FRC, area manager, or regional director. I would like to thank you for your time and attention and participation. Remember to complete the attendance sheet and email it back to me if you participated in a live Zoom session. And if you have any further clinical questions, please don't hesitate to email me at atorres@aspentherapy.net. Thank you very much for your time.